test. Okay, so I would like to call upon Prof. Nora Shikin from Department of Pathology to help us with the interpretation of these results.
Thank you very much, Medical Department, for inviting me. So let me share the thrombophilia screening test that we offer in our specialized hemostasis lab. So this is the slide that I've prepared. So when we look at the patient's result, so we can offer a series of tests to help for thrombophilia screening. So for the top three, for the protein C, protein S, and antithrombin 3 activity, so we all know that these three are our natural anticoagulant. So for cases like, for example, inherited thrombophilia or even acquired thrombophilia, we would expect that the results of protein C, protein S, or antithrombin 3 will be low. Okay, so if we see here, the protein C, protein S, and antithrombin 3 activity, I would say they are within normal limits. Alright, so no problem with that. The next test is the activated protein C resistance. So basically what we do in the laboratory is actually the screening for the activated protein C resistance for factor V Leiden mutation abnormality. If the result is lower than the normal range, then we consider to be positive. And if it is positive, then we probably would advise the sample to be sent to the National Blood Center for the molecular diagnosis of factor V Leiden or even the prothrombin G2021A mutation. In this case, this patient's result is normal. Okay, then we go to a batch of tests for antiphospholipid syndrome. So for antiphospholipid syndrome test, normally clinician, I guess, you would suspect it if, of course, with patients presented with thrombosis and also pregnancy morbidity. So in this case, it's a young lady with thrombosis, and it's at a very peculiar area in the brain. So for antiphospholipid guideline for testing, we run 3 tests. Number 1 is the lupus anticoagulant testing. Number 2 is the anticardiolipin test, and number 3 is the beta-2 glycoprotein 1. So here you see the anticardiolipin IgG as well as the anti-beta-2 glycoprotein 1. I would say within a moderate to high level. So most likely it is positive, because for this test, actually sometimes you may get a false positive result, especially in a rheumatology disease. But we'll see from the next discussion regarding this. For this, for the anticardiolipin beta-2, just now we do immunoassay testing on the solid phase. Okay, next is the lupus anticoagulant test. For lupus anticoagulant test, normally we run in 2 phases: the screening, which is the light blue one, and the confirmation. The reason why is the principle of the test is that the test will reveal the antiphospholipid character of the antiphospholipid antibody. In the sense that in the screening, we will use a reagent which has a low phospholipid to increase the sensitivity and pickup of the antiphospholipid. And for the confirmatory test is we increase the level of phospholipid, and at the end we will calculate a ratio, and by a certain ratio threshold we would conclude that this is a antiphospholipid antibody positive. So it's actually quite a tedious test, lupus, and for lupus antibody testing, it is a requirement by the guideline by the laboratory testing is to do 2 separate methods. So here in our laboratory we do a star plot PTT-LA for one method, and we use a DRBBT test method. And for this patient, both methods are positive. So I will conclude that for this patient, we have a triple positive antiphospholipid syndrome, and most likely it is a genuine positive antiphospholipid disease. So let's move on to the next slide. Just a brief principle of antiphospholipid. It's a very heterogeneous antibody. the test is not standardized, but I can assure you the test that we offer in our lab is worldwide. We have a solid phase and a liquid phase, and basically what we are testing for all three methods is to try to detect the antibody that is actually targeting the phospholipid binding protein. And the phospholipid binding protein, there are many. That's why for lupus is a good test because it will test and will be positive in all types of phospholipid binding protein. For the ACL, it will test for beta-2 GPI, it's a protein binding, and a few other protein. But for beta-2 GP1, it's very, very specific on the beta-2 GP1 protein only. And I think by the latest journal publication is the domain 1 of the beta-2 GP1 is the one that's most associated with thrombosis. So I think they are in the process of developing a more specific test for APLS. Next slide is just to show you that we actually, with the rheumatology team and nephrology team, have put up a guideline for indication for testing. So if you are familiar with the PGH guideline for indication, there are a list of clinical indication for antiphospholipid testing to test and the clinical indication for it. But for our local policy, we have add on. For SLE patient, we also set for testing. And pregnancy mobility at any stage of gestation. I think for the British Journal of Hematology, they state for one beyond 10 weeks of gestation, but here we accept all. And also we make a clause that any case that the clinician deem as an indication to test, then we will consider for testing and we will not inject the sample. Okay. Next slide. Okay, so just a little bit on the limitation of the test and the sensitivity and specificity of the test. For protein C and protein S and antithrombin 3, they are affected by anticoagulation like warfarin and heparin. So for our laboratory, patient who is on with the anticoagulation on board, we would have to reject the sample and we'll probably ask the clinician to send after treatment. It can also be falsely low in acute thrombosis and liver disease because during acute thrombosis there will be consumption of this protein C and protein S. So you might have a generally low in all three activities. So we normally would advise to repeat after acute thrombosis or thrombosis has resolved. Okay, and during pregnancy, we also have to be careful with interpreting the protein C and protein S. Protein C is shown to be increased in the third trimester. So if a patient with a genuinely low protein C, it's not a good time to send sample at third trimester because you get a false normal. Okay. For protein S, there will be a generally progressively reducing protein S level throughout the pregnancy. So we normally advise to send sample at least 6 weeks postpartum. For a normal newborn, we also have their own normal range for all three tests. For lupus anticoagulant, we would normally, if we interpret the result, we will look at the CRP level as well, because it has been shown that CRP more than 27 by the RCPA results. They send a sample with a spike, high CRP. 100% of the participant of the external quality showed positive lupus. So that is a false positive result for lupus anticoagulant. And also patient on dabigatran, direct oral anticoagulant, you will have a false positive lupus results as well. For the ACL and the beta-2 glycoprotein 1, patient with rheumatological disease can cause false positive, can have false positive ACL and beta-2. Or any immunological diseases may cause false positive results in the ACL and the 2 test. Okay, I think that's it for my part. Thanks.
Okay, thank you, Prof. Shikin. So these are the further confirmatory investigations that we have. So this patient had anti-nuclear antibody positive, 1 in 1,280 speckled. Anti-double-stranded DNA was positive. Urine analysis shows proteinuria 2+, blood 3+, and red cells in the urine with urine PCI of 0.4 gram per millimole creatinine. Okay. So at this point, so we have a young lady with sinus thrombosis secondary to APLS with underlying SLE and lupus nephritis. Okay, so quite a mouthful here. Okay, so I would like to ask Prof. Shahril. Okay, so what is the definition criteria for APLS?
Okay, Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala syafi'il anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Very good afternoon to everyone, the dean and students and also my fellow colleagues. Now, of course, when you talk about definition criteria in any rheumatology disease,